for many, many years. So thanks, Monica, for speaking today on difficult to treat Candida, yeast, fungaemia and new drugs.
Thanks, Abby, and thanks for everyone for being here today and for the people online. So I'm going to talk about difficult to treat Candida, and I thought I'd introduce it with a couple of cases from our recent past. They're not our most recent cases, but I think they do illustrate the problems. So these are the disclosures. So I'm going to talk about cases, new treatment options that are coming to us or are in clinical trials, and conclusions. So this was one of our patients a couple of years ago, a 69-year-old male with an aggressive myeloma who had type 2 diabetes and atrial fibrillation. And he was working in the UK and was diagnosed with myeloma. And he had a very aggressive presentation with acute kidney injury and also required plasmapheresis for hyperviscosity. So he was admitted in the UK for some time for treatment of his myeloma and actually went through 4 lines of chemotherapy over 12 months. And as we know from Ben Tay's work, having more than 3 lines of chemotherapy is really a risk for invasive fungal infection. So this gentleman was at quite high risk. He'd had a lot of different treatments attacking different arms of his immune system, including dexamethasone and also chemotherapy causing neutropenia. He was being worked up and he came back to Australia being worked up for a stem cell transplant, but continued to progress with myeloma. So he'd basically gone through all the treatments that were available and couldn't get to his autologous transplant. So he started to have more palliative sort of directed therapy, but still getting treated with a monoclonal antibody and radiation to his bone for his bone pain. He had received fluconazole intermittently during the course of this whole chemotherapy, particularly when he was neutropenic, and he'd had 4 admissions over the cycles of those 4 chemotherapies with sepsis, fever and neutropenia, and 2 involved admission to ICU with serious sepsis. So he'd had a lot of broad spectrum antibiotics. And then he was admitted neutropenic after receiving some melphalan, which again was given more with kind of symptomatic relief in mind, and he developed pneumonia and severe colitis secondary to the melphalan. So at that time, he was had a urine culture as part of his sepsis workup and was found to have Candida auris in his urine. It was not thought that that was responsible for his invasive or for his sepsis at that time, and he was started on meropenem, oral vanc and caspofungin empirically. However, his blood culture, which was taken at that time, revealed Candida krusei. So actually, although he had Candida auris in his urine, his sepsis was contributed to by Candida krusei. And I guess this just shows the complication of these highly immunocompromised patients where you can be colonized and have infection with multiple Candida species, and how to interpret which one is causing the infection that you're treating. But things did not go well, and this gentleman sadly passed away. Another sad case to come back to is a gentleman a few years ago who again was having extensive treatment for CLL this time, and he had multiple issues during the course of his therapy, but was admitted for an allogeneic stem cell transplant. And he had the usual prophylaxis after his allogeneic stem cell transplant with valacyclovir, Bactrim and posaconazole. And the transplant itself went reasonably well until day 135, when he presented with acute graft versus host disease. So at that point, he had diarrhea, cramping abdominal pain, and was commenced on methylprednisolone and had a sigmoidoscopy that showed that he had graft versus host disease. So again, we have a patient here who's had antifungal prophylaxis with a broad spectrum agent, and now is getting more intensive immunosuppression and has gut problems. So again, a bit of a recipe for Candida to rear its head. And so he was admitted with his gastrointestinal graft versus host disease, treated with the usual kind of immunosuppression, but did develop a Klebsiella pneumoniae bloodstream infection, not surprisingly with the gut disturbance at the time. But he also was isolated to have Candida glabrata from his blood at that same time. So it kind of come up a day or two later than the Klebsiella, and he was started on caspofungin and treated for the 14 days post the last positive blood culture. And as we can see, it was a fully susceptible to the echinocandins, although as expected resistant to fluconazole. So he was treated, but again, had not a great outcome from his graft versus host disease. He required switching from methylprednisolone to ruxolitinib, another a JAK inhibitor, and again had another positive blood culture, again for Klebsiella pneumoniae, and again for Candida glabrata. So just showing that these patients who have chronic gut disturbance continue to be at risk really for Candida infections. And again, started treatment with caspofungin. But unfortunately, he had become resistant to caspofungin. So that 14 days that he'd had previously was enough to really develop resistance in this highly immunocompromised patient. So the decision was made to treat him with liposomal amphotericin B, which was difficult in a patient, who already had issues with gut and fluids and was quite unwell. But we had no other real treatment options at that point. And he was worked up again. Previously, he had been worked up for a focus in his eyes or in his heart. And again, no focus. So presumably the focus was the gut, the graft versus host disease, the fact that the glabrata had probably never gone away and was still in his gut, and the fact that potentially suboptimal concentrations of caspofungin were getting into his gut wall at that time and inducing resistance. So I don't want to go on too much about echinocandin resistance, and as Sharon said, we don't see it very often. So this was a very notable case, and I think we need to be aware that it's more prevalent in certain areas, including the US, where echinocandins have been very widely used in prophylaxis as well as in treatment, and in certain, transplant centres where they do use a lot of prophylaxis with echinocandins, but not so common here in Australia. But of course, the risk factors are really what we expect with any antifungal: prolonged and repeated exposure, perhaps colonising strains, and perhaps suboptimal concentrations of the antifungal agent, and potentially the use in prophylaxis, as that's where the centres who do use a lot of it in prophylaxis have been the ones reporting more prevalence of resistance. So I'm going to talk a little bit now about the new drugs that are coming to us. And I think we're lucky now that we've got multiple new agents that are being explored for the use of Candida and, of course, mould infections as well. So I've just summarised them all on one slide. So this can be the end of the talk, I hope. Not really. So what I kind of have summarised here are those that have new targets of activity. And I've highlighted in yellow the ones that are being evaluated for yeast and Candida infections. So we have abrexafungerp, which is a modified type of echinocandin. It's a slightly different target to the echinocandins that we have, and so it is considered a new target, a new drug, but it really also impairs glucan synthase, as do the echinocandins, just attacking it from a slightly different angle. And it's being studied for resistant yeast, and it's also being studied in combination with mould-active drugs. What about the gaps? So along the bottom in the blue boxes. I've tried to put the gaps here. And they do say that it's active against the FKS mutants for mutations for the echinocandins, but then they're not 100% sure at this point. And you have to say that it hasn't been widely evaluated in large Candida studies yet. So there's still sort of a little bit of doubt whether it's going to work for all the FKS mutations, but definitely they believe it has activity against some of those species. So still the jury's out a little bit on highly resistant, echinocandin resistant strains. What about phosphamidopix? And this is a totally new mechanism of action, which we haven't seen a drug of this class previously. And so this will impair the particular structures in the cell wall that relate to its ability to coalesce, to form biofilms, and to have the structural integrity of the cell wall. So the cell wall is no longer protecting the yeast anymore, and so that it much more easily killed and disposed of by the human immune system. So this is a really interesting drug, but it does have a gap for Candida krusei. And so I think it's important to remember that. Although we don't see a lot of Candida krusei, I did show you a case, and we tend to see it in those highly immunocompromised patients who've had a lot of antifungals and particularly in the haematology space. So if I had a patient like that and I was going to use phosphamidopix, I might think twice about whether they could have a Candida krusei or not. I won't talk about olorifim, although it's an interesting drug because it is really a mold active drug. It doesn't have activity for yeast at all. So most of these new drugs still have a gap for mucorales, and that's important to remember too, because when we start an antifungal, we often think, well, it's going to take care of yeasts and molds, but with these newer agents, not necessarily. They're not going to necessarily, with olorifim, it's not necessarily going to cover, it won't cover yeasts, and with the newer agents, it won't cover mucorales. So then there are these other drugs that are modifications of what we already are used to using. And resofungin, as we've heard, is a modified echinocandin that we can give weekly. Not licensed yet in Australia, licensed in US and Europe. And I believe there is some interest now in bringing it to Australia, but it hasn't reached us yet. So other modifications of amphotericin B. There's a lipid nanocrystal, which was recently published as an option, an oral amphotericin B that is was an option for treated cryptococcal meningitis, and a very nice study done in Africa to prove that it was effective and less toxic than regular amphotericin B, and great, could be given orally. But there's really no more studies coming from that group. So I'm not sure if that's being progressed or not. I think it may have hit the kind of limits of what investment they have, and it's not really going to be taken forwards unless I think they get more funding to do so. So at the moment, even though it has been looked at in some yeast infections and Candida infections, and it seems to have activity, it's not really being developed for Candida at this point. And there are new modifications of standard amphotericin B. Elion is a new company set up by Kieran Ma, and this have modified the amphotericin B structure so that it has less nephrotoxicity. It still requires IV administration, but that is going into studies now as well. So the new EL219 is a modification of amphotericin B. So these are the kind of new things that are on the horizon for us, and we might take a little bit of a closer look at these. I won't go through the structure. I think this resofungin, we've probably all seen the very nice publication by G.R. Thomas looking at in the Lancet, looking at this pivotal study, which I think many of us have contributed to, on resofungin versus caspofungin, which showed that it was equivalent. with the advantage that it could be given a weekly dosing. So this was very important in getting this drug licensed, and it is still under evaluation as prophylaxis in the stem cell transplant world because of its activity against Aspergillus and Candida and PJP. So it's being looked at as a comparator to an azole for prophylaxis. But I think for Candida, the data is there and the drug's been licensed for treatment of candidemia. But we keep hearing about, is there an advantage to it? There's the weekly administration, which is good, but others have proposed that kind of because you get your highest dose at the very start of treatment, this is probably a good thing. Yes, the drug levels go down over the week and they're still sufficient to treat the Candida, but you've got in this very kind of boost right at the start with the highest dose and the highest drug levels. So is this an advantage? It's been proposed it might be. And I think G.R. Thompson did look at this pivotal study of candidemia and try and see, is there a benefit for this upfront load, so-called, with getting the highest concentration of the drug right at the start of treating Candida? So he broke the patients down, and as we know with candidemia studies, when you're screening patients, they can have a positive culture that doesn't turn positive for a few days, and then you get them onto the trial and you repeat their culture, and actually as the time they go on the trial, it's negative. They've already cleared. So he broke them down into these patients that had positives only at screening, and those patients that when they entered the trial and started the drug still had a positive blood culture for Candida. And you can see that it looks like in that green line that patients who received resofungin did clear their blood cultures maybe 50% quicker than those who received the standard caspofungin. But this study was not really powered to look at this, and so I think we still treat this. It's interesting information. It may be true that there is an advantage to the administration of resofungin in clearing blood cultures, but there's certainly no benefit in mortality, which is the bottom line, I guess. We're kind of familiar with the literature about clearing blood cultures from the Staph aureus bacteremia space, and it doesn't appear to impact mortality there either. So, there is a question about, well, is it really such a big benefit to clear the blood cultures that quickly? And I guess the jury's out on that. Abrexafunga, it's been looked at in small studies of refractory infection, and there it seemed to do reasonably well. In these studies, there were patients who had Candida krusei, who had other resistant Candida species who had bone and joint infections with Candida. So some difficult Candida cases were entered into this refractory study and seemed to have reasonable outcomes. So that is probably, at the moment, all the data we have, and it's small numbers of cases really for Abrexafunga, but a very promising agent. I think there was also, as Sharon mentioned, the Candida step-down study, which has been done looking at Abrexafunga, so treating initially with an echinocandin and then using Abrexafunga, which is available orally as an oral step-down. And again, I think that here on this slide, I show the number of Candidas that were included in this resistant IFI series that was done with Abrexafunga. So you can see it included some bone and joints, some krusei and some glabrata, and overall fairly good outcomes with it, but small numbers here to evaluate. So it may have a niche role here in where we're looking at oral therapy for prolonged periods of time, like bone and joint infection, and where we want to give oral outpatient therapy in those situations. And again, it's going to be explored in combination therapy as well for mold infections. What about fosmanogepix? There's a candidemia study running now, and we're running it. We're one of the sites here as well for that study, and it's going to be interesting to look at how it performs There is data from small studies, again, of candidemia and Candida auris. A study was run in South Africa treating Candida auris with fosmanogepix with good, reasonable outcomes. Again, not randomised studies, but again, showing promise in the treatment of candidemia. So just to go into those details in a little bit more, the Candida auris study was in the ICU, and they had overall treatment success and day 30 survival of 89%. But as you can see, it was 8 out of 9 patients. Very small study, and probably got shut down during COVID, actually. It was recruiting very nicely, but they decided to end it after the COVID outbreak. And again, candidemia study, treatment success 80%, but again, a small study with 20 patients. So thus the reason for the randomised trial now going forwards. I'm not going to talk about olorifim. I won't talk about the lipid nanocrystal, which was used in the cryptococcal study, which is the oral formulation of amphotericin, but it's a really neat mechanism of action, the way it's wrapped up in this kind of lipid particle that needs a low calcium environment, like inside the cell, where there's this low calcium environment compared to external to the cell, is where it kind of unwraps and releases the amphotericin B. So quite a nice way of stealthily delivering the amphotericin B into the fungal cell. And this is the modification of amphotericin B. It's really only a very minor modification to create EL219, just changing a side chain and really seeing a much reduced nephrotoxicity and much reduced uptake in human ergosterol. So important drug, I think, but will still need to be given intravenously. So there are a lot of implications of these new antifungals. We will have options for less susceptible invasive fungal disease, like the patients I've shown you, these resistant yeast infections. We will have still issues about gaps in the coverage, and that really brings up how important diagnostics are. And, you know, we've heard from Sharon about the PCR and beta-glucan not being the kind of answer to our prayers for rapid diagnosis, but I still think we have to work on it. I mean, you've all seen the patients in ICU and critically ill patients where the blood cultures do not flag positive for 3 days or more, and you're unsure whether this patient actually has Candida. You don't know what empiric cover to give because, you know, you don't know about its potential resistance. And I think we're still going to face this with these new drugs. We're still going to face the issue of, is it a cruciae? Can I give this drug or that drug? Is it going to be a kind of Candida resistant? And I think having better diagnostics is really going to be key to how we wisely use the new drugs. I haven't touched on it, but there is the question about combination therapy. Now that we have drugs that affect new mechanisms that are completely new mechanisms, is there a role here for combination for our difficult to treat infections like endocarditis, CNS infections, and that's all yet to be really determined. And I guess, is it going to change our approach to antifungals? If we have drugs that are less toxic, will we use them a bit more freely? Will we go back to using more empiric therapy? And that's another question, I think, that we'll face over the next few years. So I think in the mycology world, these new drugs are going to bring a whole lot of new questions that we're going to have to answer. So I'll finish there, and thanks for your attention.
Thanks so much, Monica, for a whirlwind, fabulous tour of really a whole new world of possibilities, I guess. And anyone, please raise your hand if you have questions for Monica in the room or online, and Safna will let me know. I guess, you know, the era of the 3 drug classes and thinking about treatment options is probably coming to an end. I think the brain Venn diagram of what on earth I'm covering, what I'm worried about, and what drug can I give is going to get a lot more complicated. And I think our role will be greater because we'll have to give more advice, really, being the experts in the area, which is great, I guess. Yeah, it's interesting to hear about the resifungin, and it'd be really great to have it registered in Australia. And do you have any insights into whether they're trying to apply or how long away that may be?
Yeah, thanks. I don't, and I'm not sure if anyone else does, but they have reached out to talk about Candida in Australia. They might have reached out to Sharon too. So I think they're thinking about it. And, obviously we're going to tell them Candida is a big problem and we need new drugs. So I don't know whether that will be enough because we're a small market in the antifungal global marketplace. So, we often get overlooked and get slow introduction of new drugs. But I think at least they're reaching out to talk about it. So it shows that they have some interest, and it would be good to get it.
I do have another question. I guess with the abrexafungurp and these new agents, particularly I guess with the abrexafungurp study that you presented or studies, do they do susceptibility to abrexafungurp? I mean, I guess, or is it more empirically given to someone who has thought to be a resistant candidate to the standard drugs? Because I guess, moving forward, we're going to have a whole raft of other issues with susceptibility testing if it's available, and potentially TDM and all these other considerations.
Yeah, that's a good point, Abby. So in those studies that I presented, patients got onto them by having a resistant fungus. So they did do susceptibility testing and had identified the Candida beforehand. But in the bigger candidemia studies that have been done with resifungin or now with fosmanogepix, it's not routine to have enrolment into the trial relating to antifungal susceptibility because it would take too long to get that result back and it wouldn't be timely to enrol the patient. So for these large randomised studies, no, there's no antifungal testing first. But I think it does, the more drugs and options we have, and some of them do have potential gaps, it will become very important. And it's always been, Sarah might comment on it, but it's always been a role of contention. People saying, oh, you don't really need antifungal susceptibility testing for Candida. It follows a pattern. And often it's not tested in non-sterile sites. But here, we generally do test it in Australia in sterile sites. But there are countries where they don't actually, even in blood, and just say, oh, it's a Candida albicans, it's going to be susceptible to fluconazole and caspofungin. But I think with our knowledge now, we know that we do need antifungal susceptibility testing. It's really important. And for Candida, there is the correlation between susceptible organisms and outcomes. You can argue that about some of the moulds, but I don't think you can argue it so well for Candida. So I think it is important. And the new drugs, yes, I think TDM will be important. The two patients I presented, with gut problems and, highly unwell on multiple drugs, you really would, I think, want to have the reassurance, maybe not in every patient, but, having a TDM, I think, is quite important, having a drug level. So that's a new area too, that these new drugs will open up.
Any other comments from the room? Obviously, Sarah's going to go into susceptibility. Oh, yes, we have online.
Yeah.
Is it a typed question? Okay, great. You've got Rachel there. So this is a comment from Juliette Alvey. I've always wondered whether others do consider using high-dose fluconazole for N. glabrata, susceptible dose dependent to fluconazole. I always avoid azoles, but wanted to check others' clinical practice.
Yeah, I avoid it actually because I feel like even if not always. I mean, I should back off there. I think if you're doing a step-down therapy and, you've treated and you've cleared the blood cultures and you don't have other options, but yet you've got another week to give of therapy for the 14 days, I will use high-dose fluconazole in selected patients. If someone's got highly, if they're neutropenic or they're highly immunocompromised, I don't usually. But I think there are some circumstances where I would be happy to use higher dose, 800 milligrams fluconazole. And then that also brings up the question of should you be checking on their drug levels as well if you're treating quite a, resistant fungus that you've kind of got activity of the drug at high doses. You probably do want to know that the patient's getting the appropriate level in their blood. And we've had patients where when we've gone and checked their blood, the opposite has been true. They've actually had very high levels or occasionally low levels when you think you're giving a targeted treatment that's going to work against susceptible dose dependent. But I think I wouldn't use it as first line therapy, of course not. And I do avoid azoles in that situation for first line therapy.
Thanks, Monica. I think there's actually a very recent publication in JAC publishing kind of institutional experience about using high-dose fluconazole for Candida albicans or Nicosamyces with, obviously all the limitations of a retrospective comparison, but suggesting that it may be suitable, but definitely not something that's well supported with evidence and is a bit of something we need to look into further if we're going to keep doing it. We'd like to thank Monica for a fabulous talk. Thank you. I've got a nice photo of the NCIC there. Okay, so next up is myself, and we're running ahead of time, which is probably good, probably gives us a little bit more time for lunch. I'm sure people want to eat something soon. And I have the, tremendous pleasure to talk about this stuff, which some of it's obviously ACS 1 and 2 are wonderful, but some of the rest of it might be slightly dry, so I'll try to keep it interesting and jazzy. With my jazz hands, and we do jazz hands. Sharon had actually highlighted some of the key learnings already from ACS 1 and 2, so I won't labour on some of the points, but just more to provide more of a background to those who weren't involved in ACS 1 and 2, just about the origins of things. And so, you can see the list of authors there for ACS 1. So big names and, a small group who did a lot of work. But basically the impressive thing about ACS 1 was that 50 out of 52 public and private microlabs across Australia at that point were involved in this study. So it was a really fabulous snapshot of candidemia. This was Australia at this point, of course, and these were the cases. And, it was great to see just in a local setting the risk factors that patients had that predisposed them to the candidemia. Nothing particularly surprising, but certainly indwelling vascular catheter is a strong risk, as well as malignancy and antimicrobial exposure and surgery. It did show that candidemia is associated with sepsis, with death and prolonged hospitalisation, which I think these are always great things that we can roll out to raise the case for these studies that we want to do, or there's need for registration for resofungin, for instance, that Candida, and we will be going into in ACS 3 as well, is still a big problem, still causes a lot of morbidity and mortality. And certainly in the older population, mortality is high at 28% or so, and also, of course, in infants and neonates. At that point, the Candida albicans was strongly the most common, and I'll show a figure in a minute about age groups, and then parapsilosis, and at that point called Candida glabrata. This is probably slightly small, but hopefully projects to a degree, but basically breaking down the types of Candida you were seeing by age group. And in the neonates, classically we know that Candida parapsilosis is a common pathogen, probably to do with lines in those poor neonates in NICU. Likewise, in infants, there's still parapsilosis is quite prominent, as well as albicans. But then over age, as you age, glabrata becomes more prevalent or more of a concern. Then cut to the ACSII, which was in over 2014 to 2015. And again, you can see the authors there, many familiar names. And at this time, it was 29 labs across Australia with 227 cases of candidemia. And I think it was a well-done study, and to the credit of the whole ANZMIG and ACS group, confirming the species identification at reference laboratories, as well as, gold standard susceptibility testing, or at least uniform expert reading of susceptibility testing was well done there. The annual population incidence had increased potentially, or at least was observed to be higher compared to ACS1, so maybe the problem was getting more prevalent, as were the number of hospital separation mean incidents there. This is trying to highlight the change, or the proportion of Candida isolates in this study. And of note, I think last time glabrata was about 15%, and in this case it was nearly 27% was Mycosomyces glabratus. So really quite a changing landscape, and we'd be very interested to see what the next one will bring as to the proportion of cases that are to do with albicans versus other species. This was the table in the study, and I'll break it down for some learning points now as far as the susceptibility, and Sharon had alluded to some of this, of course, but I guess some points to highlight were that in the most common Candida species, basically ambisome was still highly effective, or at least was tested to be susceptible or wild type. So ambisome is still, despite our reluctance to use it, is still something that's quite likely to work. In albicans, thankfully, the resistant or non-wild type was very uncommon. And so nice to see that, and certainly no resistance there shown to the echinocandins. Of course, the one that we tend to face that's a lot of a challenge for us is the Mycosomyces glabrata, and as Sharon had mentioned, the resistance was fairly low, and we see a lot of susceptible dose dependent to fluconazole, which is kind of nice to see if we're comfortable as a step down potentially. We've discussed this just before as to how comfortable we are or not. Then parapsilosis was still very susceptible to fluconazole and the azoles, which is lovely to see. Probably the problem child was tropicalis, and was a surprising finding, I guess, that there was quite a significant amount of susceptible dose dependent as well as resistance or non-wild type, and interestingly in posaconazole, only 29% was tested to be susceptible. So that's an interesting thing, and I guess in the era of us using a lot of posaconazole prophylaxis, it'd be really interesting to see what that looks like in the next iteration. I apologise for it being small, but hopefully I've highlighted some key findings there. Nicely, even if there was resistance to an azole or an echinocandin, in this study there were no cross-resistant isolates. Obviously this is pre-Candida auris, which is a caveat, Candidazyma auris, I should say. Sorry, Sarah. Thank you. And also, as part of the ACSII, there was a sub-study that some centres participated in, and you can see the authors here, really diving more into the risk factors and trying to look at predictive model for candidemia, because as Monica mentioned in particular, oftentimes we're faced with a sick patient in front of us. There's a possibility of Candida going on in this patient. When do we really want to give empiric therapy, or, in the absence of very good diagnostics? So in the case control, there were 8 institutions with good representation of heme malignancy, solid organ malignancy, and 40% ICU. So that's worth noting. Risk factors, again, were common with central venous access and urinary catheter. I guess some nice facts here, there's always that controversy about, who needs an echo, and particularly the pushback from ophthalmology about who needs eye review. So in this study, and we will look at it again in the current ACS3, is how many patients actually have found to have some kind of eye infection or cardiac infection. And, you know, again, those nice statistics to throw around when arguing for treatment of and need for study in Canada is the mortality was actually, unfortunately, very similar to the last study. So, you know, we have a way to go with Candida and candidemia. This was a nice Kaplan-Meier curve kind of differentiating between urologic and intravascular device mortality, if that was the source, versus gastrointestinal and unknown source. So, and I think this is fairly logical because urologic would obviously often imply, you know, UTI, which we know the source. If we manage the urine tract and obstruction, then we can often get on top of things. And obviously, intravascular source, we can deal with source control with the line. But the gastrointestinal and unknown source are often those really messy patients who have intra-abdominal badness or a gut graft versus host, as Monica had mentioned, and things that are just a lot harder to source control and manage, and are often in ICU and have been in hospital a long time. As far as risk factors or risk predictors of mortality, these are listed in the table, and basically these were the ones that were statistically significant, being older in age, being in ICU at diagnosis. These are things that are not surprising, but just validating. No prior surgery, any hematologic malignancy, any organ dysfunction that's chronic, as we mentioned, the gastrointestinal or unidentified source, and whether you've had heavy antimicrobial exposure. And we're able to pull together a predictive score that basically was probably the most helpful to show that if you had a very low risk score, you were much less likely to die. So ACS3, what's different? So we call it ACS because that's easy to say and everyone knows it, but it's not just candidemia anymore for many reasons. One is that things aren't called Candida anymore, but also because we do actually want to explore the other yeast fungaemias, which are actually very poorly described in Australia. No one's done it much in a bigger scale. And so we really don't know what other fungaemias we see. And so this is a fairly not very good map that I drew of the sites that are involved so far in the study. So 53 Australian sites and 16 New Zealand sites. Special thanks to Arthur Morris for being the lead with New Zealand and really drumming up support there, which is fabulous. And we have representation of all states and territories, multiple sites. It's very exciting. And thank you for all for being part of it. We're not doing a case control study, and the risk factors that we're collecting are the most important. We're trying not to be too labour intensive with data collection. And as I've mentioned before, things have changed, and so this will be the first one that will likely capture some Candida auris. So as I said, I think I might need to pull out the jazz hands for some of this discussion, but just going over some of the nuts and bolts of the ACS3. And so we have the ethically approved study protocol with the sponsor being Melbourne Health. I'm the coordinating PI, and Monica and Sharon are other senior lead investigators. We have management advisory committee and diagnostic subcommittee as listed there. And so the aims of the study are kind of in many ways similar to ACS2 in that we would like to explore the epidemiology, the microbiology, the susceptibility profile and outcomes of yeast fungaemia. But as I mentioned, we've expanded it to all non-cryptococcal yeast in bloodstream infections across Australia and New Zealand. And like in ACS2, we're going to compare what's happened over 10 years and what has changed, which will be great to see. And we will explore those key risk factors and patient risk groups. So the inclusion criteria are basically all patients with Candida and other yeast pathogens recovered from blood across a single calendar year, which was 2024. We are excluding those who have invasive Candida but not identified in the blood, as well as cryptococcemia. And we will look at subgroups of age, which I think is obviously quite important, including particularly neonates. The case identification ideally will be through the laboratory search and database, which obviously is something that can be done more easily when the lab is institutionally based. However, we do have several private labs who have signed up to be part of the study and are able to share data with the study, with the clinical sites to input that information as well. We have a waiver of consent. Obviously, this study is really not possible with consent for many reasons. And we encourage, particularly because we're looking at not just Candida or Candida-like, but other yeast in blood, we are wanting to put all the isolates in the database, but we'll curtail the amount of data we collect for those that are presumed to be contaminants. So there's an initial part that will be collected for every isolate, and then will be assessed as to by the site as to whether this was deemed to be a contaminant or not, based on whether treatment was commenced for that pathogen, or if a patient died, whether it was identified posthumously. And of course, Sarah will talk about lab susceptibility, etc. Things becoming increasingly complicated as far as sending isolates interstate and with the sensitivities of ethics. So at this point, we're not sending isolates to the reference laboratories that have not been sent as per routine care already. We have mentioned that we will compare to ACS2 and ACS3. We will also be looking at the population incidence and hospital incidence as per last time, and also ranking the yeast fungaemia compared to other common isolates. Is it, because oftentimes, say in America, that it might be E. coli first and Candida second, actually. So as a whole group of Candida and Candida-like yeast, they're actually a very prominent player in the blood, but it'll be lovely to see where that stands up in Australia. And we'll look at outcome data on day 7, 14 and 30. So this is probably telling you how to suck eggs, and it will be very similar to the non-Aspergillus mold study led by Zoe, because that was a well-oiled machine that worked well. So we will basically have, study participant log that we'll issue to you with obviously the key columns, and then we will issue unique study numbers to enter into REDCap. And obviously it'll be, because of the different models of lab, collection of these isolates, it would be good to, we will be recording where the isolate was worked up, in which lab, and the date of isolation, just so we can really make sure that we're not entering multiple isolates in the database. And certainly we'll be, I guess I can reassure you that the first few sites that will be starting to do data collection will be obviously heavily piloting and going through the process to iron out any issues there, so we can make sure that it runs well. Okay, so again, needing some jazz hands, but we, what's the time now? I think I will, just thinking whether I start or whether we just have a break for questions and lunch, and then we'll go into the case report form after lunch. Are there any questions in the room or online about anything I've said or any of the process? I should mention that we've got fantastic Sapna with us, who has been instrumental, and I'm sure you've seen her emails and been wonderful with the correspondence, organising governance, etc. And I will talk in a little while about a bit more about governance and anything that you might need help with there. So in the absence of any questions or anything, oh yeah, Sharon, hi Sharon. Hang on one second.
Are there any problems that you've identified so far in the ethics submission and getting sites on board, and governance issues at non-Victorian sites?
So, so far, Sapna probably can speak best to it, but I guess things have progressed to a point where we are about ready to submit things. We just have to wait for the final with our contract, the DTA. So that's why we haven't got issues yet. until we have the contract and then submit, and then there probably will be inevitably things that we'll have to work through. But we have been, obviously, with the multiple different governance structures and systems in the different states, I've had to register for, upteen number of governance websites and whatnot, but we're doing okay so far. Sapna?
Yeah, so far no issues. Yeah. We're just making our way through all the states. So fingers crossed for the rest.
Yeah, and Sapna's been working very hard. All right. Any other questions in the audience? Or
it's
hi,
not
Zoe.
a question, but probably I just wonder if, let's say, for the sites that's been involved in the non-especially small study, we actually have the DTA being reviewed as well. So probably can actually fasten the process of reviewing because, happy to know the sites.
Yeah.
Yeah.
Awesome. I think we're literally a email reply away from them being happy because we've responded to things. So I think this person went on leave basically, so we're just waiting for them to come back. But if there are any hiccups, we will definitely look at if there's more site specific things. Yeah, because that will be really helpful. Yeah. Yes, thanks, Zoe. And I definitely will be tapping you on the shoulder for various things because you've done a great job with NAM. Anything else? Awesome. I think it's lunchtime. So I think we'll mute the room, but please feel free to stay online or rejoin with the same link. We'll be reconvening at, I think it was 1:30, wasn't it? So we'll have about an hour for lunch. So 1:30 we'll be back, and you'll see more jazz hands from me, then with a fantastic presentation from Sarah afterwards. So please stay on the line, and we'll see you soon. Thanks, guys.